After coronary artery disease, we have another session on heart failure. May I call upon the chairperson, Dr. Manojit Mukherjee, and Dr. Navonita Chakraborty, and Dr. Krishna Basurai to come over the dais and to start the session.
So we start our session. Most important thing in the first deliberation, diabetes and heart failure. Most common thing but difficult problem to everybody. So I request Dr. Dipankar Ghosh to come on the podium.
Good afternoon, ladies and gentlemen. First, I must thank the organizers for having me here. I have been asked to talk on diabetes and heart failure. This is extremely a vast topic, and an entire conference can be arranged on this topic itself. So I will try to justify the topic inside 20 minutes. So basically, this slide shows that India is the diabetic capital of the world. The prevalence of type 2 diabetes has increased by 30% globally in the past decade, with the number affected increasing from 333 million in 2005 to 425 million in 2017. And India shares almost 1/5 of the entire global cases. Now, we learned in our old school days that major complications of diabetes are microvascular or macrovascular. The microvascular being dependent on the glycemia levels and the duration of diabetes. The macrovascular, even after mainly they are affected by atherosclerosis. But if you think that that's the complete picture, well, you are missing the elephant in the jungle. So basically, the jumbo is the heart failure. Now, whether incidence or prevalence, heart failure in diabetics are far more common than in the general population. And in heart failure cohorts, the prevalence of diabetes range from 10 to 47%. The reverse way of thinking is that in diabetes, 9 to 22% of the patients are in heart failure, which is 4 times greater than in general population. Of course, if you think that what may be the risk factors, of course, the first thing that comes is possibly ischemia, and the odds ratio are highest for ischemia. You may also expect that the patients may have renal dysfunction or hypertension. That's fine because they are having long-standing diabetes. But surprise, females have a higher risk of developing heart failure in diabetics, and yes, insulin use causes heart failure in diabetics. Yes, you heard me right. It is insulin use which is causing heart failure in diabetics. Now, these long-term studies all show that females have more chance of developing heart failure in diabetics than male population. So it's basically a conundrum. For each 1% increase in HbA1c, the risk of heart failure jumps from 8 to 36%. And for 1 millimole rise in the fasting glucose, the risk increases by 1.23-fold. Now, the trends that has been seen that almost half the patients in heart failure are diabetics, and the population is equally distributed to have heart failure with reduced ejection fraction, heart failure with borderline ejection fraction, and heart failure with preserved ejection fraction. The problem, real problem, is that we now understand that glycemia invites this heart failure in diabetics. But glycemia control doesn't cure the problem. UKPDS, ADVANCE, ACCORD, and VADT all have shown that if you have a tight glycemic control, people are not living longer. That's the problem. So it takes a U-shaped curve. So this is a fantastic meta-analysis done by Castagano, and it shows that tight blood sugar control not necessarily means that the patients are living longer. In fact, potential harms of tight blood sugar control are inviting hypoglycemia, pill burden, treatment burden, and now the guidelines push that if the patient has too much comorbidities, target a more lenient HbA1c around 7 to 8%. So coming to the pathophysiology of diabetes, one is the straightforward pathway of ischemic cardiomyopathy, which develops by accelerated atherosclerosis. But at the same time, the other arm, the green ones, are showing that you have LVH, you have increased fibrosis and autonomic dysfunction, which invites a stage called diabetic cardiomyopathy. Together, they lead to heart failure in diabetes. Now this ARIC study, they have shown that patients who are diabetic but not in any form of complications, they tend to have higher biomarker levels like HS troponin or NT-proBNP. I mean, their HS troponin levels are not as high as in the MI patients, but they are higher than the normal population, thus suggestive of subclinical myocardial damage always going on. So if you look at the pathophysiology of what's causing diabetic cardiomyopathy, there's a host of agents which lead to diabetic cardiomyopathy. And I think and I feel that altered insulin signaling is the most important of that. I would take a few slides just to make you understand what this altered insulin signaling pathway is all about. Now insulin, once it binds to the insulin receptor, it triggers this insulin receptor substrate, and these kinases, they become active. And finally, AKT1 activation leads to a host of cellular processes, like it prevents BCL2 and therefore preventing apoptosis. It prevents FOXO from going to the nucleus, prevents autophagy, and it promotes cell growth by mTOR activation, and it promotes vasodilation by increasing the eNOS and promotes glycogen synthesis. Most important is that it transports the GLUT4 vesicles to the cell membrane so that glucose can now enter into the cell. Now it will be very simple to think that in insulin resistance, this pathway is deranged. That's exactly what happens in skeletal muscle, liver and adipose tissue, and as a result of which you have lot of high sugar, fats in the blood. But something different is going on in the heart. In the heart, plain and simple, if you see that in the early stages, in insulin resistance, the GLUT4 translocation is reduced, but the IRIS1 and the AKTP1, they are overactive, and as a result of which cardiac hypertrophy takes place. So in the early stages, you have a hyperaction of this IRIS1 pathway, which leads to cardiac hypertrophy, which is pretty different from what's happening in skeletal muscle or liver. But in the late stage, the IRIS1 AKT path 1 get burnt out, and you find apoptosis, autophagy, cell loss, and finally dilatation. So the initial pictures in echocardiography of diabetic cardiomyopathy, you tend to find hypertrophy, and in late stages, you tend to get dilated cardiomyopathy-like picture. So this concept has been proved by, if you ameliorate this hyperactive IRIS1 receptor or insulin receptor, these patients do not develop LV dysfunction. The other problem that's coming up also is the crosstalk between the insulin receptor and the beta adrenergic receptor. So the main culprit here is the GRK2 protein, which sets up this B2 adrenergic receptor, becomes active, and it leads to its deleterious effect. So blocking these beta-2 adrenergic by vasodilating beta blockers or very high doses of paroxetine, which is an antidepressant, so has been found to have protective level. So I am talking about these because these treatment modalities may be the future therapy in diabetic heart failure patients. Another important feature I would like to highlight here is the altered myocardial substrate metabolism. Normally, heart is very energetic, requires a lot of ATP, and the majority of the ATP comes from fatty acid oxidation. At the same time, heart is very flexible. It can use a lot of substrates if fatty acids supply is diminished. It can use glucose, lactate, ketones, and amino acid, but their availability is around 20 to 40%. What happens in insulin resistance or heart failure? From now on, these are the synonymous terms, because any patient who has heart failure has some amount of insulin resistance. So what happens there is the glucose entry is diminished, and the heart tries to burn more fat because that's the only substrate he is dependent on. But burning fat requires more oxygen, so the heart technically becomes inefficient. Later, even long-chain fatty acid entry gets reduced, and the heart is ultimately dependent on ketones. Ultimately, the heart is an energy-starved state. The mitochondria die, and the cells disintegrate. Proof of this theory also that in ischemic cardiomyopathy, we tend to use a drug called trimetazidine, which tries to switch from fatty acid to the glucose metabolism or glucose substrate. And technically, though it's not used in heart failure, but it has a role in ischemic cardiomyopathy and got a class 2B indication. Also, theoretically, ketone body utilization by infusion of 3-hydroxybutyrate in heart failure patients has been found to be beneficial. So, a few more things about myocardial biogenetics, like increased ROSC, they tend to do the uncoupling of the electron transport chain. And there are pharmacological interventions in the future which are going to tackle all this. Lack of time, I'm leaving all these topics. Like this, when the glucose main pathway is not being used, the glucose tends to get converted into glycolytic backup like mannose, sorbitol, or galactosamine. So all these have got their deleterious effects on heart failure. And autophagy is also a very important action. Initially, autophagy does prevent left ventricular hypertrophy, but in the late stages, autophagy and apoptosis lead to cardiac dilatation. So initially, RAS blockade, metformin, and resveratrol are the agents which tend to help autophagy and prevent left ventricular hypertrophy. Now coming to the therapies, what we can use in patients who have diabetic and established risk of heart failure, you see in potential harm, I placed sulfonylureas, thiazolidines, insulin, certain DPP-4 inhibitors like saxagliptin, allogliptin. And there are a host of agents which are very popular among the diabetologists, but they are potentially neutral. Well, the beneficial agents stand out only in heart failure tend to be metformin and SGLT2 inhibitors. Now, metformin is a wonder drug, and in our school days, we thought that it was contraindicated because in acute heart failure, it caused lactic acidosis. But the UKPDS study has demonstrated substantial benefit in the metformin use, and from now on, in view of this finding, FDA has removed the contraindication to metformin use in heart failure in 2006. Now, there's a paradigm shift in this concept of metformin because the metformin is now been shown to have pleiotropic effects. It's got its antisclerotic effects, vascular endothelial protection effects, reduced LDL-C, anti-inflammatory effects, and it lowers statin-based passive stiffness, which is a predominant mechanism in heart failure with preserved ejection fraction. And also it reduces arterial calcification. Sulfonylurea, since the publication of UGDP study, that is the University Group Diabetes Program, and which showed that tolbutamide invites heart failure way back in 1960. And they also shows that they tend to cause weight gain, fluid retention, hypoglycemia. But here I want to tell you that it's not a class effect because sulfonylurea receptors in the pancreas is SUR type 1 and in the heart it is SUR type 2A. So there are recent sulfonylureas which are coming up in the market like shown in Advance and Carolina trial. Advance with glyclazide and Carolina has had with glimepiride as a comparator, and they did pretty well even in heart failure. So it's not a class effect that all sulfonylureas will invite heart failure, but the potential of having heart failure are there with sulfonylureas. Sulfonylureas tend to block potassium-dependent ATP-dependent potassium channels, and they invite calcium entry and cause insulin release. Now, these same potassium channels are used as vasodilators, or they are helpful in ischemic preconditioning. So these are something crosstalks that sulfonylureas cause deleterious effects in the heart. Insulin. Rightly, I said that insulin invites heart failure. Initially, Origin trial, UKPDS and BARI 2 did not demonstrate that insulin cause increased rates of heart failure, but observational studies are showing that insulin increases heart failure, or drugs which increase insulin in the body, they invite heart failure. Now, why this happens? Because patients who are on insulin, they may be sicker or they may have a longer duration of diabetes. Water and sodium retention are occur, so increased congestion features are there. Increased episodes of hypoglycemia and its complications. Adrenergic activation is there. Hypokalemia, they cause lethal arrhythmias and a prothrombotic states. And most important, like I said in pathophysiology, they stimulate the GRK2 beta adrenergic signaling pathway with its deleterious effects in the heart. Coming to thiazolidine, which does decrease insulin resistance and is a PPAR gamma agonist, so it had a lot of promise, but in heart failure it causes heart failure mainly because by causing renal sodium reabsorption and thereby increasing volume expansion. Now this class GLP-1 receptor agonist, now these are incretin-based therapy and they are wonderful anti-diabetic drugs. But if you look at particularly two drugs, lixisenatide in ELIXIR trial and exenatide in EXCEL trial, they did not show any significant cardiovascular benefits, and most important, there was no difference in impact in heart failure hospitalization. But the other drugs like liraglutide, semaglutide or dulaglutide, they do show some promise. Bottom line message is that GLP-1 receptor agonists regarding heart failure, they are neutral, no impact on the increased risk of heart failure hospitalization. So people tried whether GLP-1 agonists can be used as heart failure agents. the 5 studies showed that this liraglutide it got a negative result. So next group of molecules that I like to discuss is the DPP-4 inhibitors, again an incretin-backed therapy. And the most important is the saxagliptin and allogliptin, particularly saxagliptin in SAVO trial. They showed that they had got increased risk of heart failure. And this led FDA to entirely blanket this DPP-4 class as an agent that increases heart failure. Future trials with sitagliptin, linagliptin, and vildagliptin did not find that they cause increased heart failure. But please be careful, because vildagliptin has been shown that there is increased LV dimensions in the trial, in the VIVID trial, but no increase in biomarkers. So why saxagliptin when the entire DPP-4 class is such a wonderful drug? So why saxagliptin in SAVOR TIMI-53 and allogliptin in EXAMINE trial had increased incidence of heart failure? Because the group which was using the drugs also was using thiazolidine. So probably they think that thiazolidine were the agents that cause these deleterious effects. Now coming to this wonderful and wonder drug in heart failure, finally, is the SGLT2 inhibitors. And all 3 drugs like EMPA, CANA, and DAPA, they have been shown to have decreased heart failure incidence as well as a very positive outcome on cardiovascular endpoints. So people think that they excrete glucose and sodium through the urine. So basically the diuresis is the main cause of this such extremely useful cardiovascular effects, but that's not true. SGLT2 inhibitors also have a protection against pancreatic beta cell failures. As seen in this PET scan, people on EMPA see that the pancreatic functions are pretty preserved. So apart from sweet pea, they have got certain other pleiotropic effects as well. So both this canvas and the EMPA-REG with canagliflozin and EMPA-REG, they showed that these drugs, they cause reduction in heart failure hospitalization. And this year only, John McMurray came up with the DAPA-HF outcome trial, and which showed that this dapagliflozin is also decreasing heart failure. So how do they work? So this is a slide that's got a lot of advantage. So the bottom line message is that sweet pea to sweet spot in heart failure. So summary of now that we come to the drugs, the cardiac drugs that can be used in diabetic patients with heart failure. And we all know that ACE inhibitors, ARB, are beneficial. But the main talk here is about ARNI. And it's a wonder drug that is used in heart failure with reduced ejection fraction. So in the Paradigm heart failure trial, ARNI has been shown to be providing a lot of benefit in heart failure. And this sacubitril valsartan this combination does a trick on the glycemic control also in diabetic patients, to the tune of 29% reduction in new insulin use compared with enalapril. Now, these neprilysin inhibitors, they improve glucose homeostasis, they cause weight loss. So by this, they are a good drug to use in this combination. Beta blockers, vasodilatory beta blockers, they are neutral. Mineralocorticoid agents, they can also be used. Spironolactone does increase diabetic incidence, but eplerenone has reduction in diabetes, and the other agents you can use safely. And I must end my talk with talking about bariatric surgery in obesity and diabetic patients. Caloric reduction does do benefit. So these are the various therapeutic pathways that I have discussed. Future therapies are going to take up these signaling pathways. And that my take-home message would be that diabetes mellitus and heart failure go hand in hand. Insulin resistance and hyperinsulinemia triggers intracellular signaling pathways, which initially cause hypertrophy but later on dilatation. Myocardial cells become energy-starved with altered mitochondrial bioenergetics and breakdown. Therapeutic benefit in this condition comes from drugs which cause volume depletion with additional metabolic modulation. Now, for a classical patient with diabetes and with heart failure with reduced ejection fraction and no renal impairment, I would prefer metformin with SGLT2 inhibitors and ARNI with a vasodilatory beta blocker, eplerenone, and statin. This is one part of science where basic science, medicine, cardiology, endocrinology, and nephrology march together. I thank you all for your time and your attention. Thank you.
Now the session is open for the questions and comments. No question, then we can conclude the session. Thank you very much. Thank you.
Good afternoon, and I think we are already running pretty late. We're almost an hour and a half late. So I've just made the slides a bit lesser because I think we've already been sitting through the session a lot. So my talk is to talk about a new molecule, that is the ARNI, also being branded as Vimada, and its role in cardiac remodeling. I think we are all aware that heart failure is a major problem for all our patients, and heart failure is one of the commonest cause of hospitalizations. And I think what happens is that most of these patients, not only do they get admitted, but the only other problem is that they tend to get readmitted. So almost 44% of all our heart failure patients tend to keep coming back with heart failure within the first year itself after discharge. And this is not just the data which is global, this is the data which is also local. So when we had the Indian heart failure and we had the Trivandrum heart failure registry, this also had a similar data which was similar to the rest of the world, where we saw that there is a similarity between all genders. So whether it's the men or the women, each of them is equally affected with heart failure. And as I said, the readmission rates are pretty high. Anywhere between 25 to 30% of patients get readmitted within a year of their first episode of heart failure. And this again is something which is pretty distressing for many of our patients, where economics also is an important factor. And as I said, it's just not the economical factor. It also means that patients who get readmitted also have a higher mortality. So if your patient keeps coming back to the hospital with readmissions with heart failure, we also have to understand that his overall mortality is also much greater. And this was a problem that we had to always tackle despite the medications that we are using. And as Dr. Dipankar already talked about it, the beta blockers, the ACE inhibitors, the MRAs, these still had a mortality benefit. But over and over that, we also had this new novel molecule known as the ARNI, which had blocking effects on the RAS inhibition as well as blocking the neprilysin. And this was the trial which showed the paradigm heart failure trial, which showed that as compared to enalapril, ARNI had a much greater benefit. And this was a great effect. I mean, we are talking about a 20% risk reduction of overall mortality. Not many trials have been powered to have such a great mortality benefit, and this was one of such great trial which showed a superiority of ARNI over an enalapril itself in heart failure. And based on this trial, we had the recommendations on the ACC-AHA guidelines, which put it as a class 1 indication, where in patients where you still had heart failure despite being on ACE inhibitors, you could switch them over from ACE inhibitors to an ARNI to get an additional benefit. And this was the strength of this data of the paradigm heart failure trial. So we started looking at why exactly these patients did so well. And the major reason was that we have to understand that why does this patients go into heart failure? What happens to a heart in these patients? And the basic thing that happens is that I think we all understand is the inappropriate remodeling. And this is something that we had learned way back in our physiology days also. And there's something known as remodeling that happens. And this involves changes in the cardiac structure. There is a myocyte death, there is myocyte deformation, and all of this leads to a dilatation of the heart. There is an eccentric hypertrophy and an increase in the left ventricular end systolic and the end diastolic volumes. Most of the treatment protocols have gone towards what we call as reverse remodeling. So whatever changes have happened in the heart muscles, we want to get it back to a normal size, we want to get it back to a normal shape, and that is where these researchers have gone to try and reverse the models to make sure that these patients have lesser heart failures. So as I said earlier, in patients who have a heart failure with a reduced ejection fraction, again a sign of warning, we are not talking about heart failure with a preserved ejection fraction. We are talking about heart failure with a reduced ejection fraction. And in these patients, because of the volume overload, there is a dilatation of the heart, and over a period of time with chamber enlargement and eccentric hypertrophy, there is a volume overload. And this is condition of volume overload causes a thinning of the ventricular muscle. It also causes a reduction in the systolic function, and over a period of time, a reduction in the LV, increase in the LV volume also. So the therapeutic strategies for heart failure reduced ejection fraction was basically to try and correct these pathophysiological changes. So what we had to do is to try and correct the hypertrophy. We had to make sure that we could get rid of the apoptosis and the necrosis. And again, as I said, try and achieve a reverse remodeling to get back to a normal heart again. We had, again, this is a busy slide, and this talks about the different drugs that have been used earlier. We had the renin-angiotensin aldosterone mechanism. We had beta blockers to block the sympathetic nervous system. And this is the novel molecule, the Vimeda or the RNA that we're talking about, which has additional benefits not only on the RAS inhibition, but also on neprilysin inhibition. And this is the relationship between, what is the relationship between cardiac remodeling and prognosis? And we had studies to say that one of the most important indicators of your survival benefits is your ejection fraction. We have enough data over a period of time in many studies to show that the lower the ejection fraction, greater is your mortality. So if you had an ejection fraction that was more than 45%, the chances of your survival is much greater as compared to a patient who has an ejection fraction less than 35%, both in terms of heart failure hospitalization as well as in terms of arrhythmic deaths relating to sudden cardiac death. It also is based on the shape and this function of the valve. The mitral valve, we know, is a dynamic structure. Whenever there is a dilatation of the chamber, the mitral valve apparatus also gets stretched and there is mitral regurgitation that sets in. A mitral regurgitation again causes a further aggravation of your left ventricular function by causing again a volume overload of the left ventricle and causing an ineffectual contraction of the ventricle. And we have enough data to say that not only the systolic, but the LV diastolic function also gets compromised in a patient with LV dysfunction. And these are the various remodeling patterns, and each of them, these studies over a period of time have shown that patients who have remodeled hearts, so if you have a LV modeling that has already happened or your LV has already got remodeled, both in terms of hypertrophy or dilatation, there is a greater chance of having both not only cardiovascular death, but also strokes and heart failures. And the studies are mostly targeted to show that if you could correct this, for example, if your ejection fraction improved, you could see that your mortality suddenly drops down. So for an ejection fraction that was less than 35%, as I said, your mortality is much greater. As your ejection fraction improves, your sudden cardiac death mortality would also tend to come down. As your heart pumping becomes better, your size of the heart or the volume, left ventricle end diastolic volume increases, there also causes an increased risk of death. So as your LV function reduces, the diastolic component of the heart or the filling of the ventricle would be much greater, and all of this would contribute to a worsening of your outcomes. And the same goes with your left ventricular end systolic volume also. If your heart is not pumping adequately, at the end of your systole, there would be a great amount of volume that is left behind in the ventricle, and if your baseline end systolic volume is high, your chances of mortality also tend to go greater. And this is a study where we looked at the impact of the prognosis of heart failure along with left ventricular end diastolic volume and end systolic volume. And what was shown is that even if you could improve if there's an increase in the left ventricular end diastolic volume or end systolic volume by even a small amount, even a 10 ml increase in your systolic volumes could increase your risk of death or heart failure hospitalization from anywhere between 9 to 15%. So in effect, it may look a very small matter, but all of this or a cardiac remodeling also has a greater effect on cardiac mortality. And this is where the results of the CHARM trial was also looked at. And here, this was basically with candesartan, which is another ARB. And what was shown is that once your ejection fraction reduced, there was a greater chance of heart failure hospitalization and cardiovascular death as compared to patients who had an ejection fraction that was much better. Again, the same thing which talks about the left ventricular end systolic volume, and we had devices such as the cardiac resynchronization therapy device, and what it does is that we synchronize the heart so that we pace both the left and the right side of the heart, and we use the heart synchronously so that we can improve the effective cardiac output. And in this group of patients where the CRT group was looked at, what was found is that as your left ventricular end systolic volume was reduced by even 10%, it translated as an improvement in mortality also. So with a cardiac resynchronization therapy, if you could remodel your heart so that you could reduce the left ventricular end systolic volume, a small amount of reduction in end systolic volume translated into a greater benefit in terms of reduction of cardiac mortality also. And the same thing which happens with left ventricular end diastolic volume also. So like the systolic volume, even a reduction in end diastolic volume will also translate into improvement in your ejection fraction and translate into greater cardiac benefits. A reverse remodeling with Vimeda has been shown in the heart failure reduced ejection fraction studies. And the basic mechanism, well, this is a very busy slide, but this talks about the various proteins where the two drugs work on. And this basically helps to reduce or to cause a reverse cardiac remodeling. So Vimeda basically does, what it does, it acts by reducing the cell death and also prevents the eccentric hypertrophy. And all of this basically translates into a better cardiac remodeling. And we have data from clinical trials which have talked about the use of this drug with Vimeda, and benefits have been seen as early as within the first year itself. So within 3 to 12 months of use of this drug, we have seen that there has been a reduction in the mitral valve regurgitation status, there has been an improvement in the mitral valve flow patterns, and an increase in the ejection fraction with a reduction in the end diastolic and the end systolic volumes. Again, this is also important to see that the ejection fraction does not grow up. You don't need a very dramatic increase in the ejection fraction, so it does not go up from, say, 20% to 60%, but a small amount of improvement in the ejection fraction also will benefit these patients, and this benefits both in terms of heart failure hospitalizations as well as in terms of a sudden cardiac death. So if you had to use this drug in, say, 10 patients, at least 7 of these patients would improve in terms of an ejection fraction, and this was seen in the Paradigm HF trial also. Again, it is important to see that we are not talking only of idiopathic dilated cardiomyopathy. We are also talking about ischemic cardiomyopathies. And in these trials, as many as 80% of these patients were patients who had had a previous angioplasty or a previous bypass surgery, and they were on this novel molecule. So improvement in Vimeda is both for ischemic subsets as well as patients who have an LV dysfunction relating from an idiopathic dilated cardiomyopathy. And again, as I said, this improvement happens within a period anywhere between 3 months to 12 months of use. Of course, the data is to continue this even beyond the 12 months also. But amongst these trials, when these patients were added onto Vimeda, despite being on optimal medical therapy, when I'm saying optimal medical therapy, which means that these patients were already on beta blockers, they were already on MRAs, and they were on the other antiarrhythmics also. And as like I said again, what it does is that it reduces the left ventricular end diastolic volume as well as reduces the end systolic volume significantly when you compare them over the baseline without the use of Vimeda as compared to enalapril. So basically, to look at this, what happens is that not only does the Vimeda reduce the remodeling, there's also a reduction in the mitral flow inflow patterns. So this is also important because many of the echocardiographic follow-ups that we do, we look at the mitral flow inflow patterns to look at how your remodeling is happening, and there is a significant reduction when the use of Vimeda is used in this group of patients. And again, this benefit is dose dependent. So the guidelines talk about using 200 milligrams twice a day, and that's the optimal dosage that we want to reach. Of course, we do start with a smaller dose in this group of patients. We do start with 50 milligrams twice a day, and then build up based on their hemodynamic response and their creatinine response to try and reach 200 milligrams twice a day. And as I said earlier, the increase in the ejection fraction happens pretty early in the course of the disease, and within a period of 3 months in this trial, we could see that there is a significant improvement in the ejection fraction. So I think what we need to understand is that there are larger trials going on which are looking at the use of Vimeda in ventricular remodeling or on large vessels also. And 2 such trials what I would like to mention is one is the Evaluate HF trial, whereas compared to ACE inhibitors or enalapril, Vimeda has been compared in a 1:1 fashion in a double-blinded trial to look at the aortic stiffness. So this is one of the indirect methods to look at the ventricular remodeling to see how much is the resistance. And this trial is going to look at a randomization over a period of almost 2 years. And as I said, this is a double-blinded trial where the first runoff within the first 12 weeks is double-blinded with Vimeda and enalapril. And after the 12 weeks period, it's going to be an open-label trial where these patients are going to be on Vimeda alone. And the other trial that we are talking about is the PROVE-HF trial. And this trial is also going to look at the NT-proBNP, which is one of the markers of heart failure. And it's also going to look at cardiac remodeling assessed by echocardiography. And all these parameters that we talked about, end systolic, end diastolic volume, left atrial volume index, mitral inflow patterns, to see how much is the baseline as compared to a 1-year follow-up. And these 2 trials are basically, we are still awaiting the results of these trials. And these will give us an idea about how the remodeling happens with Vimeda as compared to the other optimal medical group that we have. So to summarize, we know that heart failure is a major disease for us. Patients have a problem of coming back with rehospitalizations, and we know that these rehospitalizations have a mortality effect also. We now have a new novel molecule, which is the ARNI or the angiotensin receptor neprilyzing inhibitor, Vimada, which can improve remodeling in these patients with heart failure. And not only on those patients who are not been on these medications earlier, but also a switch can be made from ACE inhibitors or ARBs to RNE for those patients who have been on optimal medical therapy previously. Thank you for your patient hearing.
Thank you, Dr. Khan.
Yeah.
Now this session is open for questions. Is there any question?
One question, please. Long-standing diabetic patient having CKD, creatinine clearance about 45 to 50, had this dilated cardiomyopathy. It has been detected now. Now, what should be the ideal treatment for this patient?
Right. So I think this is a very good question. The first thing is that we need to identify and try and identify correctable causes for the LV dysfunction. And we know that, as Dipankar also talked about, there are many causes which can produce LV dysfunction, and ischemia being one of the commonest cause. So in these patients, we need to evaluate and find out whether the patient has an ischemic component, whether there's an episode of reversible coronary artery disease, whether there is angina or reversible ischemia that we can tackle. And this could be by means of a treadmill, or for patients who are not very active, by means of other imaging modalities, a dobutamine stress echo or a stress thallium, or any other methods to find out whether there's reversible ischemia. Now, as you said, the patient already has a kidney disease. So therefore, the decision in terms of making a decision in terms of further invasive management, say an angiography or a further bypass surgery or an angioplasty, will be based on the area of risk. So if the patient has a large area of myocardium at risk where not treating the ischemia is going to produce LV dysfunction, then I think it may be worthwhile taking a risk and going ahead with an angiography. But if there's a small amount of area at risk, then probably optimal medical management with anti-anginals may be good enough for this patient. The second thing also is correction of correctable factors, as I said, like of hypertension or many other correctable factors. Diabetes per se itself, you need to correct diabetes well to get a good amount of LV function improvement. And as Dipankar also presented, we have data with the SGLT2 inhibitors, the DAPA-HF, which also have shown benefits. Now, amongst the molecules that we're talking about, RNE that we talked about just now, the guidelines are not to use it beyond less than 30 ml creatinine clearance. So one has to be careful once using RNA in this group of patients, and one must repeat a creatinine clearance even in the borderline group to say that we are not ending up with hyperkalemia or a worsening of the creatinine factors. So beta blockers can probably be used safely. We can use the other medical pump that we used to talk about, Aprosol with nitrate, with a nitrate inhibit, with a oral nitrate. So preload and postload both can be reduced with nitrates and with Aprosol. So these are good drugs with hydrolysine. So that these are good drugs to use in this group of patients. And of course, judicious use of diuretics also. So one has to be again balancing risk of causing symptom benefit vis-a-vis increasing the creatinine and worsening the creatinine clearance by increasing too much of aggressive diuresis in this group of patients also. So again, I think there are a lot of correctable factors that we need to first identify. And again, as I said, try the best optimal medical therapy, both in terms of the beta blockers, ACE inhibitors, preload and afterload reduction. And if at all the borderline more than 30, we could try RNE still in this group of patients.
Thank you, Dr. Khan. We are moving to the next speaker.
Next speaker is Dr. Shanko Subrosen, tracking resistant bug in ICU. Please, Dr. Sen.
May I start? Slide. Good afternoon.
a post-lunch session, a bit sparse crowd, but those who are here are changing topic, shifting to antibiotics, its usage in the ICU, and tackling resistant bugs. I feel with all specialties, the most mortality nowadays in the ICU are related to sepsis. And this sepsis should be tackled as early as possible. And my topic will be on antibiotic usage in the ICU by tackling resistant bugs. We all know that there is no escape from these escape bugs nowadays. What are the escape bugs? Enterococcus faecium, Staphylococcus aureus, Klebsiella, Acinetobacter, Pseudomonas, and Enterobacter. These are bad bugs, but there are very less drugs. I can't say no drugs, so there is no escape. So, what is our target? Our target is to prevent infections, diagnose and treat infections as early as possible, prudent and rational use of antibiotics, that's my point today, and prevent transmission of multi-drug resistant organisms. Now in numbers, it's a huge number. And there are around 10 million deaths per year it's suspected to be around 2050. And 90% in Asia and Africa, that is in the third world countries. So by definition, what is MDR? That is multi-drug resistant, is resistant to at least 3 classes of antimicrobial agents, including all penicillin cephalosporins in one group, or fluoroquinolones or aminoglycosides. So at least 3 class of antimicrobial agents, if the bugs come out to be resistant, it is called multi-drug resistant. If this is also resistant to carbapenems, which is our now the main medications in dealing with MDR infections, then we say it extremely drug resistant, that is XDR organisms, and pan-drug resistance, when the isolate that is resistant to also polymyxins, which include colistin and also tigecycline. So these MDR, XDR, and PDR all are very much important bacteria which we deal day in and day out in our ICUs. In Indian scenario is also frightening. The antimicrobial resistance pattern of the causative organisms in the MICU in an Indian tertiary care hospital in 2015, it showed that there was resistance to carbapenems in 35.2% of the persons studied. And among these, MDR Acinetobacter and MDR Pseudomonas comes into the picture as the most dreaded bacteria. Regarding rural hospitals, another study, this was done in 2015, it came out in 2015, and it showed that in Sebagram, Maharashtra, the prevalence of MDR was around 26.9%, 7.4% of XDR, and 1.9% of PDR. So this drug resistance is a huge menace in our critical care settings and taking many lives. As you all know, sepsis by definition is life-threatening organ dysfunction caused by dysregulated host response to infection. It's not the infection itself, but the dysregulated host response to infection is sepsis. And when it is associated with persistent hypotension, which requires vasopressors and that cannot maintain a mean arterial pressure of 65 millimeter of mercury or a serum lactate level of more than 2 is septic shock. So we lose many patients to septic shock. So severe sepsis with septic shock can be prevented if we can treat early. A patient, we have to diagnose the person early. The definition of sepsis and septic shock keeps on changing, and the sepsis 3 is the current definition as I discussed just now. So to diagnose early, we have a criteria that is quick SOFA. The SOFA, as you all know, is a huge criteria. There are multiple number of criteria which you should take into account, but by the Q SOFA, we look into if the patient has altered mental status, if the patient in the emergency room comes with a faster respiratory rate and a low blood pressure of around 90/60 or below, then if any of these criteria is present, then we can take this patient as sepsis and don't delay in initiating treatment. That is, initiate antibiotics early, and if there is shock, we have to take care of shock by huge amount of fluid resuscitation and also vasopressors like noradrenaline, vasopressin as the case may be needed. But for a decision for antibiotic, there are many doctors involved. Not only the intensivist and the primary physician, the infection control team in the hospital, a microbiologist in charge, the clinical pharmacology team, and also the cost factors, and here the administration of that particular ICU comes into the picture. So this decision for antibiotic is very important. And the antibiotic guidelines vary between ICUs, and this variation is based on also on local causes of infection, resistance patterns, availability, patient factors, and everything. And very importantly, the local causes of infections are very important. For that, we need to have a good microbiology backup so that we should know our antibiogram. Which antibiogram we should follow according to the last antibiogram, as the statistics will show in our hospital what our bacteria comes out to be in the culture sensitivity reports. For inadequacy of antibiotics, the main problem is the antibiotic may not cover the infective organism. The pathogen can be resistant to the antibiotic, the dosing may not be adequate, and combination therapy was not used if indicated. And the common errors is, suppose I am treating an infection, but that is not an infection, it can be a colonizer. So we should keep that into mind. We can treat too early, but if we treat too early, we have to de-escalate the antibiotics as early as possible, as soon as the culture reports come or the patient improves. And also, we cannot wait for too long to increase the dose of antibiotic or give proper antibiotics, try to give proper antibiotics. The wrong target, poor penetration are other issues, and very importantly, I will discuss a few points on PK/PD issues. And error in indications, some fever are there which can mimic infection, but we should keep in mind central fever, cancers, allergies, and systemic inflammatory response syndrome, that they may be, the fever can be there, but that may not be related to infection. Initiating too late is bad nowadays. Don't stay there still time or maybe next time, because it can be too late. We start antibiotics empirical as early as possible, because like in myocardial infarction, we said time is muscle. Here also the time is very important. We should start antibiotics. See, this important study, it showed that the time from hypotension onset and the delay in introduction of antibiotics increases the mortality in large number of patients. So we should start early, and we should try to cover the probable pathogen which we think of in the ER itself, and even the first dose should be administered before shifting the patient to the critical care unit. And this impact of delayed initiation of antibiotic treatment has been hugely studied, and this delay is not permitted nowadays, because we can't lose patients due to a delay in initiation of the first dose of antibiotic from the ER itself. So fever may not be always infection, leukocytosis may not always mean infection. We should take care that colonization may be there, and presence of devices doesn't mean that there is always infection. Here's a huge chart. These are the non-infectious causes of fever. We should keep in mind like the myocardial infarction, a GI bleed, or a pancreatitis. These things, or even a CVA, a blood transfusion, can lead to fever. They may not related to infections. So we should begin antibiotics intravenously as early as possible, always within the first hour of recognizing severe sepsis and septic shock. And procalcitonin comes into the picture over here, because the high procalcitonin is very important, but this procalcitonin helps mainly while de-escalating the antibiotics that I will discuss. Empiric therapy should attempt to provide antibacterial therapy against the most likely pathogens based upon the presence, illness, and local patterns of infection. So if something, Acinetobacter is very important or most commonly found in critical units in suppose Kolkata, XDR Klebsiella may be more common in our setup in Siliguri. So the local patterns of infection are very important, and for patients with difficult to treat multi-drug resistant bacterial pathogens such as Acinetobacter and Pseudomonas, the empiric therapy is very important, because their combination antibiotics should be started from the beginning if the case is known or patient case is suspected to be of these organisms. And also in neutropenic patients with severe sepsis, the same thing comes into the picture. So combination therapy comes into the picture in those cases where we see the patient is more sick. So a combination of beta-lactam and the macrolide can be used for patients with Streptococcus pneumoniae. We should consider empiric therapy for neutropenic patients, as I mentioned. But after 2 to 3 days or 4 days of time, when the culture reports come, we have to de-escalate the antibiotic or change the antibiotics as the culture reports may be, or the patient may be improving. And antibacterial should not be used in patients with SIRS infection states, as I said, if they can be found to be of non-infectious origin. Like complex combinations might be needed in settings with highly antibiotic-resistant pathogens are prevalent, and with such regimens, we should incorporate carbapenems, which are doing commonly. We need to use colistins in MDR cases, and rifampicin and other agents may be used. Empiric combination therapy should not be administered for more than 2 to 3 days or 3 to 5 days, because by that time either the patient is improving or the culture reports have come in. And that will prevent emergence of resistance. And the duration of therapy is usually around 7 to 10 days. In the ICU, longer courses may be needed in patients where there are undrainable focus of infection, if there is a bacteremia with staph aureus, or there are some fungal or viral infections, and in presence of immunologic deficiencies and neutropenia. Antiviral therapy is also indicated in certain cases of viral sepsis, particularly if I think of patient of coming with H1N1, we should send samples and use oseltamivir from the beginning in those cases where we are suspecting a swine flu. So the decision to continue, narrow, or stop antimicrobial therapy must be made on the basis of clinical judgment and clinical information, but we should also know the antibiotic gaps. A carbapenem I use from the beginning, and I should keep in mind that it will not cover the MRSA or the MRSA, Enterococcus, Tenotrophomonas, Burkholderia, and even if there is a fungal sepsis. So a single carbapenem may not be enough. What are our failings? Our failings are to hit hard and hit early, failing to cover all likely pathogens, and failing to de-escalate when the time comes. If I fail to de-escalate, there are more chances of emergence of resistance. So initiating too early or even for too long is deleterious. For patients, when there is suspicion of hemodynamic instability, if there are neuromeningeal symptoms, if the case is already known to be a case of neutropenia or a history of splenectomy, we should start early as possible. And for stable patients, we can wait for till an hour. But as early we start, we have to de-escalate as early as possible. There are various studies which say that 8 to 15 days course of therapy for ventilator-associated pneumonia, but many studies nowadays favor in a shorter course of antibiotic therapy. And there is evidence for procalcitonin. Procalcitonin is nowadays used for various purposes, but procalcitonin is not used only for detecting sepsis. It's better that if the procalcitonin level is coming down, then we can de-escalate our antibiotics as early as possible. And there are certain guidelines for continuing or stopping antibiotics. If the concentration comes down to a certain level, we can stop the antibiotics. If the decrease is less than 80%, we can continue the antibiotics. If there is increase in concentration of procalcitonin after 2 to 3 days or 4 days of time, we have to change antibiotics. So the reason for antibiotic delays are also very important. Our emergency rooms are overcrowded, and there is inadequate staffing, there is delay in patient transfer and all. So we should take into account of these factors, because we should start antibiotics at the beginning as early as possible. So we should know our local epidemiology that I mentioned, and very importantly, this culture. Send cultures from the beginning as early as possible. Send the blood cultures at the beginning. If there is endotracheal intubation is already there, you send tracheal aspirate for culture. Urine culture is very important. And if there is a wound infection, send the wound swab for culture in the beginning, because that will dictate us in the later part of the treatment that where we are heading to. If the patient is improving, it's fine. But if the patient is having a downhill course, that will help. So for optimizing antimicrobial therapy, we should keep into mind the PK/PD, which is studied in our pharmacology classes. And for sepsis, it's very important because there can be low plasma concentrations of the medications, because in sepsis, there is a leaking of capillaries, as you all know, and there is alteration in protein binding. So there is an increase in the volume of distribution of the medications. Thus, there can be low plasma concentration of the drug. On the other hand, if there is a multi-organ dysfunction syndrome, if there is an end organ dysfunction like a renal dysfunction, there will be decreased clearance, and there will be high plasma concentration of the drugs. So we should keep these in mind while adjusting our dosages in septic patients. Even for the peak by MIC, like an aminoglycoside should be given in a short dose. It can't be given in a longer course of time. A T by MIC is very important for time over MIC, for beta-lactams, clindamycin, erythromycin, linezolid. For these molecules, we should give it in an infusion of around 3 to 4 hours. A meropenem given in a shot will not work well. A meropenem should be given at around over 3 hours infusion. Imipenem, cilastatin, or a doripenem also in the similar way. But if we give an amikacin over 3 hours, it will not work, because we need a peak concentration as early as possible. So aminoglycoside should be given in a short single dose. So we should keep all these points in mind while treating patients with sepsis. For colistin, we should give it a loading dose of 9 mu from the beginning, and then continue with 3 mu TID, or adjust the dose accordingly, according to the creatinine clearance. Similarly, the dosage are very important, because these medications need initial loading doses, because that will help the organisms to be killed. So using PK/PD, we should give the protocol should be in our hospitals to give infusions, maintenance doses for piperacillin, tazobactam, meropenem, and cefepime, all these penicillin group of medications. Like to summarize, suppose I am thinking of a patient to have a pulmonary source of sepsis. If it is a community-acquired pneumonia, we can use a beta-lactam and azithromycin, or a beta-lactam or a respiratory fluoroquinolone like levofloxacin from the beginning. If this is a healthcare-associated pneumonia, we have to add an anti-pseudomonal beta-lactam from the beginning, plus minus an aminoglycoside or a vancomycin or linezolid as a gram-positive MRSA coverage. Suppose I am thinking of catheter-related bloodstream infection, then we can't wait. We have to start a gram-positive MRSA coverage of vancomycin, an anti-pseudomonal beta-lactam, and an aminoglycoside. If there is a risk of fungemia, we have to add a fluconazole or echinocandin. If the source is of an urinary one, we can start with the third generation cephalosporin plus minus an aminoglycoside or a fluoroquinolone. If there is history of urological interventions or there are chances of MDR risk factors, anti-pseudomonal beta-lactam should be added. If the source is unknown, then we can't wait. We have to add an antifungal if there is a risk. We have to start with an anti-pseudomonal plus MRSA coverage with vancomycin or so. So barriers should be taken care of, as I mentioned. We should start timely antibiotics, and we have to overcome the barriers as the cases may be. Regarding antifungal therapy, we need and early therapy sometimes, but the diagnosis is difficult. There is a role of presumptive therapy of antifungals. The challenges in diagnosis is there is no clear-cut, acute, rapid method to diagnose fungal infection. For these patients, we need a good clinical suspicion index, and there are certain methods by which we can categorize the patient, whether the patient may need an antifungal also from the beginning. There are certain scores like Candida score, the colonization index, corrected colonization index, Ostrowski score. These take into account certain criteria by which if the score is above a certain level, then we can start an antifungal straight away. Regarding antifungal, if the patient is hemodynamically stable, you start with a fluconazole. If the patient is hemodynamically unstable or in a bad shape, we can't wait. We have to start with an echinocandin, which is preferred as early as possible. But very importantly, nowadays, we are reconsidering our old options. A molecule like colistin is a very old molecule. A phosphomycin is also a very old molecule. As we don't have new medications in our armamentarium in near future, we are now using these older molecules which were discovered even more than 50, 60 years back. And these molecules have come back, and these are helping us to treat septic patients. So colistin, phosphomycin, these are old molecules which are now saving patients of XDR organisms. There are certain studies where showed that phosphomycin, colistin, these help in these patients where there is carbapenem resistance. So at the end, there is a 30% rule for antimicrobial prescribing facts. 30% of all hospital inpatients are given at any given time receive antibiotics. Over 30% of antibiotics are prescribed inappropriately even in the community. And 30% of all surgical prophylaxis may be inappropriate. 30% of hospital pharmacy costs are due to antimicrobial usage, and 10 to 30% of pharmacy costs can be saved by antimicrobial stewardship program. So we should make sure it is an infection. We should screen for MDR colonization. We should prevent cross-infection, follow isolation procedure in certain cases, and we should not delay the administration of antibiotics, which I am repeating from my first slides. Uses of empirical therapy first and try to narrow the spectrum later with de-escalation of the antibiotics, as I mentioned. We should ensure initial doses are sufficient. Underdosing should be avoided. Loading dose may be used wherever applicable. A shorter course is probably as good as a standard 2-week course in most cases. An ID specialist should be consulted when managing serious infections. And in certain cases like vancomycin and all, we can monitor the antibiotic levels when available. We should limit prophylactic use to appropriate situations, and we should have an antimicrobial stewardship program in each and every ICU where we are working. This antibiotic stewardship program helps in prevention of emergence of resistance, and we should have a whole team of working together to implement this antibiotic stewardship in our ICUs. We should clean hands, save lives, and as you all know, this hand cleaning is the most important factor. All medical and paramedical staff should be trained so that this is the basic thing, and this can help the prevention of the emergence of resistance in the patients. I thank you for your patient hearing, and it's a limited time, so I tried to hurry it up.
Thank you, Dr. Sen, for your elaborative lecture. 1 or 2 questions is allowed only.
Thank you. Okay, should I finish?
in sepsis with multi-organ failure, do you have any experience with urinostatin?
Ulinastatin.
Urinostatin.
Yes, sir. So
You have,
ulinastatin is now being widely studied, but it has not come into the guidelines till now. Ulinastatin now, till now, the ulinastatin has been used in severe pancreatitis cases
Yeah.
and in certain severe sepsis patients.
Yes.
But no guidelines, not even India, not even the European or American guidelines has prescribed it. But these are being used in a trial basis in severe sepsis and severe pancreatitis where there is multi-organ dysfunction.
Yes.
But no guidelines has come up
Yes.
with that.
yes. Thank you very much.
Thank you, sir.
So we can conclude the section here. Thank you, everybody.
কে কে ছিল ডাকুন চলে গেছে ওই তো আছেন